Hello everyone, welcome back to Nurses, the Heart of Healthcare. Keep learning, keep growing. My name is Shanaz. In our last video, we discussed regarding burns. What are burns, the incidence of burns, the types of burns and the causes of burns. In this video, we'll discuss how to do burns assessment, which is very vital part of burns management. As healthcare professionals, may it be doctors or nurses, we must understand how to carry out burns assessment promptly so that the intervention and stabilization of the patient can be followed. Okay, so as we all know that burn injuries are traumatic and life-altering events which can significantly impact the patient and their family. Burn injuries, they cause a significant insult to our body, and so a thorough A to E assessment followed by a thorough head-to-toe assessment of the patient is very important. Okay, so as healthcare professionals, we should be able to do it and carry out promptly so that the fluid resuscitation and further management of the patient can be planned accordingly. So let's move ahead. But before moving ahead, a small and gentle reminder to all my lovely viewers that if you are new to my channel, please subscribe my channel, and if you find the content helpful, please do like and share my videos. Okay, so now coming to burns assessment. When assessing a patient with burn injury, a thorough A to E assessment is vital. Okay, A to E is nothing but A for airway, B for breathing, C for circulation, D for disability, and E for exposure. Yes, in this manner we have to carry out the assessment, and once performed the patient is stable, then we can try and elicit to obtain the details regarding the mechanism of how the burn has happened. But the one more thing that we can do is when we receive a patient with burn injury in ER. Okay, suppose a patient has come with burn injury in ER. If it's a minor burn, then it will be one doctor and one nurse will be attending the patient to do the assessment and stabilization. But if it's a major burn which involves second degree and third degree burn and major parts of the body, then for sure that at least two doctors and two nurses will be attending the patient so that patient prompt interventions can be carried out and promptly the patient can be stabilized. Okay, so when other team members are doing the patient's assessment to rule out the depth and the severity of the burns and trying to stabilize the patient, one member of the team or one doctor or a nurse can obtain a detailed history, patient history, okay, which is very important. Okay, a detailed patient history regarding the burn injury, okay, when and how it has happened. So what all we need to find out is when the burn injury happened, okay, the time of burn injury, very important, the time of burn injury and the mechanism of burn injury, how it has happened, how it occurred, when it occurred and how it occurred, so that we can rule out the type of burn, whether it's a radiation burn or a thermal burn. Thermal burns are very common, or if it's an electrical burn, because electrical burns, when you examine the electrical burns, the external injury seems to be very minimal. Okay, you will see only some area of external injury, but the electrical burns, they cause a great visceral damage, okay, internal damage. So that's the reason to rule out which type of burn it is, radiation burn, thermal burn or electrical burn or chemical burn. Okay, and also need to obtain information regarding the length of exposure, for how long the patient has been in contact with that harmful chemical or whatever is the cause. Okay, and the estimated temperature of the heat source. Okay, the length of exposure and the temperature, estimated temperature of the heat source, that also should be ruled out so that it will help us to rule out the depth and severity of the injury. Okay, and if any first aid has been given to the patient. Okay, sometimes the patient will be alone. Okay, or sometimes there will be immediate family members who will respond, or there will be some other first aid responders who respond to the situation, and if there is any first aid given to the patient initially. Okay, and if it is given or not given, if it is given, what type of first aid has been given. Okay, and that also should be known. Okay, and TT also we need to give to the patient. So TT status also we have to find out. Okay, so these are the things that we need to find out in the initial history. Okay, and where it has occurred and how it has, because if the burn injury has occurred in an enclosed space, then there are more chances that the patient will have inhalation injuries. Okay, so that's the reason we need to find out the details of the time and the mechanism of burn injury. Okay, and regarding the first aid, what all has been done to the patient, so that we can do plan the next. Okay, so this is history collection. This has to be done simultaneously. It's not that the patient is lying over the bed and one is collecting history. No, the other members will be trying to stabilize the patient, and one can do the history collection from the patient or patient's family members or the first aid responders who has brought the patient. Okay, so this can be done. Then next, what we are doing simultaneously is A to E assessment. Okay, A to E assessment. A stands for airway. Okay, so first the airway need to be assessed to know the airway patency. Okay, to monitor, to assess and monitor the airway patency and breathing. Okay, so if the patient has sustained a burn injury in an enclosed space, then there is increased risk that the patient will have inhalation injury, which can complicate the condition. Okay, and if the patient is having any facial burns or any facial trauma, that can complicate the condition. So that's the reason that has to be checked. Okay, assessed. And also need to evaluate, if the patient is very critical, and if it is indicated or required, then intubation is also done. Okay, and apart from managing the airway, it's important that simultaneously cervical spine immobilization should also be done if it is indicated. Okay, with a soft padded cervical collar. Okay, if it's indicated, even cervical immobilization should be done along with the airway management. Then B stands for breathing. 100% oxygen can be administered via non-rebreather mask if it is indicated, and if burns are more extensive, okay, which involves circumferential chest burns or upper extremity burns, then if escharotomy is needed, that also can be planned. See, for breathing, they will also do an ABG to rule out if the patient is having any carbon monoxide poisoning. Okay, that also can be done, and escharotomy is needed or not, that also should be evaluated. Now, what is escharotomy? Escharotomy, to understand what is escharotomy, the first thing is we need to understand what is eschar. See, you can see here, this is escharotomy. Okay, so eschar is nothing but it is a tough inelastic mass of burn tissue that results from full thickness burn. When the patient is having full thickness burn, they will have eschars. Okay, and it will put pressure. So escharotomy, it is an emergency surgical procedure which is done within 2 to 6 hours after burns. Okay, it is indicated when the circulation is compromised, when the blood circulation is compromised due to increased pressure in the burned limb. Okay, and which cannot be relieved by simple elevation. So that time they do this escharotomy, as you can see there. It's very painful, right guys? It's very painful. Okay, so this has to be done, escharotomy. Okay, it is an emergency surgical procedure which is done within 2 to 6 hours, which involves incising through the areas of the burned skin to release the eschar and the constrictive effects to restore the circulation and allow adequate ventilation. Okay, so this can also be done for management. Then in circulation, C for circulation, too wide, because fluid resuscitation, patient with burns, they are actually at high risk of hypothermia and fluid loss. There will be a lot of fluid shifts. Okay, so that's the reason skin is the barrier which regulates the temperature. So now when this got damaged, the patient will have hypothermia. Okay, and it's a barrier against infection also. It prevents the entry of microorganisms. So now when this got damaged, there is a risk of infection. So these things need to be taken care of. So that's the reason a lot of medication, fluid resuscitation will be needed for the patient. So we need to put 2 wide bore cannulas, at least one at the beginning can be started, and we should try our best to avoid insertion from the burnt tissue if possible. If the overall body is burned, we can't help it, we have to go somewhere, but if possible, if upper extremities are burned, then lower extremities can be tried, or if EJV can be placed, that can be tried, or we have to try our best to avoid the burnt tissue, insertion through the burnt tissue. Then put a wide bore cannula, at least 18 gauge cannulas we need to put. Okay, and blood samples can also be taken simultaneously to know the blood group, screening, clotting and creatinine kinase. Okay, and for aggressive fluid therapy. Okay, and at the same time they also place the urinary catheter so that fluid balance can be monitored. We'll be infusing a lot of fluid. Okay, fluid balance can be monitored. Then D for disability. Disability in which we evaluate the neurological status of the patient, the GCS. Okay, if the GCS is less than 8, no doubt that the patient will be intubated to protect the airway. Okay, and temperature is also monitored because the patient is at risk of hypothermia. Okay, then next is E for exposure. Exposure is the patient is fully exposed to get an accurate estimation of the percentage of total body surface area involved in burns. Okay, then patient is also checked for any associated injuries. Okay, like inhalation injuries or any other associated complications which can complicate the condition. Okay, and TT booster is given as per the status of the patient. Okay, so these are the things that we do in A to E assessment. Okay, then next is, after A to E assessment, the next is assess the extent of body surface area burnt. See, there is greater morbidity and mortality for burns patient if the burns are affecting the face, hands and perineum, ears, etc. Okay, the location is very important for assessing the potential disability. And if there are any associated injuries also, like smoke inhalation, cough, then if the nasal hairs are burned, if there are oral burns, or if there is wheezing, or if there is fractures, facial fractures, or if there is carbon monoxide poisoning, if there are any associated injuries like this, then it can even more complicate the condition. So assessing the extent of burn surface area is also very important to manage. Okay, so there are various methods to estimate the total body surface area affected by burns. Okay, the three famous methods that we are going to discuss here is rule of nines, Lund and Browder method, and the Palmer method or the rule of Palm. Okay, so these are the methods that will assist the burn team in making decisions about the treatment and the transfer of the patient to a burn center. Okay, the factors that we need to consider in determining the burn depth is how the burn injury occurred, the causative agent, the temperature of the burning agent, the duration of contact with the agent, and the thickness of the skin. Okay, so these things we need to consider. So the first method that we are going to discuss here is rule of nines. It's very famous. Yes, it's a tool which is used by the trauma and the emergency medicine providers to assess the total body surface area involved in burns. Okay, it helps to determine the burn severity. Okay, it helps to measure the body surface area burned, and it is very important for estimation to know the patient's fluid requirements and hospital admission criteria. Okay, so in this method the body is it divides your body into sections by multiples of 9% each. Okay, so measurement by this method is very popular and easy to carry out. Okay, so this was devised by Pulaski and Tennyson in 1947, and it was published by Alexander Wallace. You can see his photo here. Yeah, he is Dr. Alexander Wallace. Okay, he published Rule of Nines in 1951. He is a Scottish plastic surgeon. Okay, and he is the one who published Rule of Nines. Okay, in 1951, and it is very popular, though it has some drawbacks, but still it is a very popular method of carrying out. And you know, one more thing, even myself also, I find it very easy to calculate it and easy to implement it, and we can do it very fast. Okay, rule of nines. So let's see how we are doing it. In rule of nines, yeah, as you can see here, in rule of nines, the estimation of the burn surface area, it is based on assigning percentage to different body areas. Okay, so as you can see here, I'll take it little more closer. Yeah, okay, so as you can see here, the entire head, it is 9%. Okay, if the entire head is burned front and back, it is 9%. Okay, which can be further divided as 4.5% for the anterior, that is face, and 4.5% for the back side of the head. Okay, so it is 9%. And then next, the entire trunk is estimated to be 36%. The entire trunk is estimated to be 36%, which can be further divided into anterior and posterior components. Okay, 18% for the anterior trunk and 18% for the posterior or back of the, okay, then which can be again further divided as 9% for the chest, anterior chest, and 9% for the anterior abdomen. Okay, and 9% for the posterior chest and 9% for the posterior abdomen. Okay, like this. Then upper extremities, total it is 18%, and it can be further divided as 9% each. So right upper extremity 9%, left upper extremity 9%, which can be again further divided as 4.5% for the upper arm and 4.5% for the forearm. Okay, so like that, anterior and posterior. And lower extremities are estimated as 36%, 18% each lower extremity, 18% for each lower extremity. Okay, again this can be further divided, 9% for the anterior and 9% for the posterior aspect. And the perineum part, okay, or the private part, the groin, it is 1%. Okay, may be male or female. So this is how the percentages are given in rule of nines. Okay, it is in multiples of 9. But one limitation of this rule is, for obese people and for infants, it cannot be applicable. There are some limitations. Okay, for infants they can use rule of 8s, and for obese again the BMI has to be calculated, and there are some considerations. Okay, so many other rules for estimating a burn size can be applied to the patients who are obese, okay, based on their body shapes, okay, based on the total body surface area. Okay, so this is how rule of 9 is done. It's easy to remember. Yes, for head, anterior and posterior, 9%. For the entire trunk it is 36%. For the upper extremities it is total 18%. For lower extremities it is total 36%. And for the perineum or the private region it is 1%. So altogether it is 100%. So based on this, the body surface area can be calculated, and this body's total body surface area, it is put in the Parkland formula to calculate the fluid requirement of the patient, and fluid resuscitation is done accordingly. So this is very easy to do, and easy to remember, and practically it is very easy. Okay, so that's a benefit of rule of 9. The next method is the Lund and Browder chart. Okay, this was developed in 1944, and it is most broadly used tool worldwide to calculate the total body surface area of a burn, and it is most accurate graphical record, okay, of the extent of the burn. Okay, comparatively, when they have done some comparative studies of rule of nines and Lund and Browder and the Palmer method, they found Lund and Browder to be 3% more accurate to calculate the total body surface area of burn compared to rule of nines. But the thing is, and this is more practical for children and infants. The Lund and Browder chart is used to assess the burn chart, okay, body surface area, because in kids what happens is, in infants they have proportionately larger heads, which alters the surface area contribution of other major body segments. Okay, so rule of 8s is better approximately in infants weighing less than 10 kg, and what we say, this Lund and Browder chart, it is a gold standard in calculating. I mean, it is more accurate, but it is quite difficult. Even I don't use it much in practically. I mostly follow rule of nines. Okay, so Lund and Browder chart, it is little difficult practically when you apply it, and quite difficult to remember also. Okay, so this is how they calculate. We got to remember these percentages. Okay, it has to be done in this way. Fine. The next method is the Palmer method, or the rule of Palm, which helps in estimating the total body surface area, and it is it is an easy way to get a rough burn size, and it can be the Palmer method is the simplest calculator of the burns, okay, burn skin percentage, and by utilizing the patient's palm, what they do is, this technique is ideal for the small and scattered burns. So when there are small and scattered burns, this technique is very helpful. See, this is how. So if it's a patient's palm, not our palm, okay, patient's palm is considered as 1% of the patient's body surface area, okay, his or her body surface area, patient's palm, not our palm, and you can see the percentage here. Okay, so if it is see, for pediatrics, if it's complete palm including the fingers, it is 1%, excluding the fingers it is 0.5%, whereas for adults, including the fingers, if you are considering, then it is 0.8%, and excluding fingers it is 0.5%. So this is how, using Palmer method or rule of palm, the body surface area is calculated. It will give a rough idea of the burn surface area. Okay, it is simpler calculator, and it is very helpful in case of small and scattered burns. Okay, but again it is limited by user and the patient variability. Fine. So these are the different ways in which burn severity and depth can be calculated for fluid resuscitation and for the further management of patient with burns. So this is how we carry out the burns assessment. Okay, it's very important for us to understand and do a systematic approach so that it can be done promptly, accurately, and we can do prompt stabilization of the patient in pain, because burns, as we know, that the patient is in very bad pain. Okay, so pain management is also very important apart from fluid resuscitation and protecting the patient from hypothermia and infection. Okay, so hope this video has helped you in understanding regarding the burns assessment. If you like the efforts, then please do subscribe my channel, and if you like the find the content helpful, please do like and share my videos. So as we all know that medical science is so deeper than a sea. Okay, so there are a lot of things to learn, so please try your best to learn something new every day, apply it and teach it to the others also. Okay, so knowledge is meant to enlighten self and others. We should not keep it with self. Okay, then try to be a better human every day. Okay, and try to help others. Thank you so much for watching, and thank you so much for motivating me. Stay connected with Nurses, the Heart of Healthcare, for more interesting videos.